Welcome to our webinar on Zika and the nervous system, emerging lessons for emerging viruses. Especially warm welcome to all our Zika Plan friends and colleagues. Also our friends from Zika Alliance and Zika Action. Special welcome to scientists and professionals from all around the world interested in the complex issues of Zika. Zika Plan is a research consortium funded by the European Union's Horizon 2020 Research and Innovation Programme to address knowledge gaps for Zika. One huge and a really central piece of our consortium and our almost 5-year project was dedicated to the neurological complications of Zika. And we focus on basic science, clinical research, capacity building and training and networks. A really exciting session is ahead of us. And without further ado, may I hand over to Professor Tom Solomon, who will be chairing this webinar. Over to you, Tom, and thank you.
Thank you very much, Annelise. I'd like to add my welcome to everyone who is joining this seminar on Zika. So I'm Professor Tom Solomon. I'm based here at the University of Liverpool in the UK, and I lead the NeuroZika work packages along with my friends and colleagues Hugh Willison and Bart Jacobs. And we have a great collection of people who are going to be talking today. And I'm just going to ask everyone to turn their cameras on and give a wave so that you can see the fantastic lineup of speakers and participants. Come on, guys, turn them on, give a wave. Excellent and fantastic. So they'll be joining us throughout the afternoon. We have a series of people who are chairing each session, and we've allowed plenty of time for questions and discussion. If you want to move on to the next slide, that's some of the housekeeping, I think. The webinar is being recorded. Your videos and microphones have been disabled as attendees, but we do want to hear from you. And in fact, what I'd like all the attendees to do now is in the chat function, just say hello, tell us where you are listening from, and maybe about your interest in this program, whether you've been involved in the program or whether you're just interested in Zika and emerging viruses. And that will also tell us whether the chat function is working. So post your messages now. If all the attendees would like to just say hi into the chat function, then we know it's working. And as so you can post messages as we're having our talks, and make comments there. Also, you can use the Q&A function, which you'll see down at the bottom of your Zoom screens. I'm sure everybody's familiar with this now, and we'll address those questions after each of the talks. So I don't think there's masses more I meant to say. If there is anything, if someone from the Global Health Network wants to remind me if I've forgotten anything, and I would like to thank the Global Health Network team for providing the support for this meeting today. But if I've done all the things I'm meant to have done, then we will move on. And I'll hand over to Dr. Fatima Militao from Fiocruz, Brazil, and she's going to chair this first session. Fatima, over to you. Okay. Well, before we hand over, guys, I'm not seeing anything in the chat function, which makes me worry it's not working. So maybe some of the panelists could type in it, and maybe Bonnie and the team could just check it's working. And we'd like a setup where everyone can see the chat. So if you can make that setup so anyone can see the chat, that helps the dialogue. There we are, Hugh Willison's there, excellent. So what about, we know we've got at least 74 participants. Does anyone want to just post into the chat and tell us where they're from? It's what we normally do for these things. I don't think we're asking too much. There's Taran Dua Nickling. Okay, good, it's working, great. Well, let me hand over now to Fatima and Maria Lucia Brito. Fatima, over to you.
Okay. Hello, I'm Fatima. I'm an epidemiologist at Oswaldo Cruz Foundation in Pernambuco. Good afternoon, good morning for everybody. It's a pleasure to participate of this webinar and see how much you have learned since the beginning of 2015, when neurologists in the northeast of Brazil noticed an increasing numbers of cases of acute neurological disease, looking for care at emergency rooms. Many of these patients related an asymptomatic disease before the neurological manifestation, and their PCR test done at virological laboratory in Oswaldo Cruz Foundation, Pernambuco, showed Zika virus infection. Dr. Lúcia Brito, Chief of Neurological Service of Restauração Hospital, attended most of these patients and is going to speak about her experience at that time attending these patients. Lúcia, please. Lúcia will have 10 minutes to talk, and after her talking, we are going to have 10 minutes to discuss and to receive your questions.
Okay. May I make a little sharing? Sure. Yeah. Okay. Thank you, Fatima, and also the team from Zika Plan. And I would like to thank the possibility to share with this audience the work that we start during the outbreak of arbovirus since the end of 2014. This is my conflict of interest. And we start emphasizing that before Zika outbreak, we prepare the Department of Neurology at Hospital da Restauração, elaborating the database and enhancing the medical record, at least in some areas, such as neuroimmunology, infection, epilepsy, stroke, and so on, and with some main focus, such as assistance, presentation in web meeting and congress, directed to the neurological communities, and also publication. At the end of December 2014, in the first months of the year, January 2015, we identified that we are facing an outbreak that should be arbovirus. And then we, after some discussion with our team, we decided that it's not dengue, but maybe some other arbovirus, because we identify the increasing number of neurological diseases linked to viral infections, such as GBS, ADEM, encephalitis, and others, and with the previous history of infection, and then to decide that should be Neurozika. Just to focus on this, in this graphic to show you when we faced the outbreak of dengue during 2001 and 2, we realized that an increased numbers of GBS, and also in 2006 and 7. But when we started to see these cases and during the period of 2015 and 16, we realized that there is an increasing number of, for example, GBS cases, and call attention to the what are happening during that time. And the first publication that we organized to call attention to the neurological communities was this publication with the group of Rio de Janeiro, calling attention to Guillain-Barre Syndrome and associated with Zika virus outbreak that are happening in Recife and also in some cases in Rio de Janeiro. This timeline show how we work inside the hospital and also with the Fiocruz team, trying to organize our cases and laboratory to identify what are happening during this time with these new cases with neurological disorders. And and at the end of 2015, the Minister of Health identified the hospitals in Recife and also in a city nearby Recife as a hospital, sentinel hospital, to identify all the neurological cases that appear in the emergency room that was referred to these places, and also the labs that should work up our samples. And after that, we have some meeting with health professional from this municipalities, states, and so on. And also with the team of Fiocruz, we organized the research and submit to FACEP to support our work. And step by step, we did some adequacy in our database to include the patients. And also we discuss with the team of University of Glasgow and also in Ribeirão Preto, São Paulo, because we know that they are identifying some cases there. And we enhanced the clinical and neurological protocol adequacy of our data bank and start to include the patients. And then this team decide to be called as Neurozika, and we submit our research to ethics committee of Fiocruz, and after approval we start to all the cases that we are facing during this time, and then we also take part in this wonderful meetings that occur in some places to discuss the problems of Zika and also other arbovirus related to neurological disorders. And as a result of this, we did our first publication that was in a tropical medicine and hygiene with our 6 first cases of Zika virus infection that you face in different ages, and with this sort of signs, clinical signs and symptoms, and the interval between disease, clinical symptoms, signs, and neurological complications. And all these cases were positives, PCR positives, and 2 of them with virus isolation. And also step by step, as we call in this publication, we did other publications related to Guillain-Barre Syndrome as a very huge team, and also a systematic review and meta-analysis about Guillain-Barre related to Zika virus. And also our case series, prospective case series with immunological disorders related to Zika and chikungunya is a very great number of patients included in this work with the central nervous system compromise and also peripheral, mixed, isolated cranial nerves and other disorders. And now we are preparing the group of the other disorders. We include stroke, and we are preparing our small number of patients that present with symptoms of stroke after infection. And we have 5 cases of mono-infection, 7 double infection, and 2 dual infection, Zika and Chik. And this is the publication that we are now waiting for. These two papers were accepted to be published in the next maybe 1 or 2 months. This is the differential frequencies of HLA, DRB1 and DQA1 and DQB1 alleles and haplotypes that were observed in arbovirus-related neurological syndromes that you study with a group of Agil Magalhães and Fiocruz. And the other one is a cytokine soluble HLA-G levels in acute and recovery phases of arbovirus infected in our group of patients with neurological complication. And there's a very important papers that we are now waiting for the publication. And I would like to emphasize what we learned with the Zika outbreak that should be useful for SARS-CoV infection. And maybe we have to include this to resist the fallacious feeling that the problem is resolved. We know that it's not resolved yet, while it's only in its seasonal behavior. To act in clinical practice, we have to emphasize that our team and other neurologists around Brazil, that we act clinical practice with an epidemiological perspective, to assume the role of knowledge multiplying public, private services, and for distance location, trying to discuss cases, present how to do the diagnosis and how to assist these patients, and to understand that the challenge in opportunity to start a point for developing a line of research. I think this is a message that you learn from Zika and you are practicing with SARS-CoV nowadays. And I'd like to express my gratitude for this huge and important group, and that we start studying these cases, and initially as NeuroZika and in a sequence with as a team of Zika Plan, and express my gratitude to be chosen as a speaker in this opportunity. And I think I am able to ask some questions that you propose for me. Thank you so much.
Hello.
Thank you.
So, thank you, Lucia. Very good. We have a question from Dr. Lida. During the outbreak of GBS and Zika, did you notice increase in severity or differences in clinical presentation with GBS associated with other potential etiologies? Lida Osorio.
Yes, I think we analyze these cases one by one, trying to emphasize the behavior of the GBS in these cases, but was not so different from the other cases that you face in another time. And maybe we are preparing the children cases, and maybe we have some cases severely affected differently from the group of adults.
Okay, I can add some information. We done a systematic revision with meta-analysis with Sonia, and we found that the GBS cases associated with Zika virus infections needed more ICU assistance, and the duration of hospitalization was were greater. Sonia, you can comment about this.
Yeah, yes, I can comment about that as well. Yes, you're right. So the GBS patients that had a recent Zika virus infection had high rates of ICU admission, higher than you would expect based on literature on GBS patients that had a different kind of infection. So this suggests that maybe Zika virus-related GBS is a more severe type of GBS, which I think is what you were aiming at, huh?
May I add some comment?
Yes, I was wondering.
Okay.
Because
I think the cases that we identify as having a dual or co-infection, we realize that they are more severe than the others. But if we compare the other cases, it's not so strong as we saw in our everyday life. But when we compare with the children, I think we have more things to add.
Julia, Edgar has a comment, I think. Julia, go ahead.
Lucia, thank you for your nice presentation. You mentioned a publication that's about to appear by Almeida et al., where you talk about disease and resolution and cytokine production. How do the levels of cytokines correlate to disease versus resolution?
Yes, we identify that there is some decreased level of anti-inflammatory cytokines in the acute phases of this the serum of these patients when we compare with the control group. And differently, we have more inflammatory cytokines in this group than in the other group, and also less anti-inflammatory cytokines.
Okay. We have also a question from Dr. Hugh Wilson. Hello, Lucia. What are the commonest infections apart from Zika that trigger GBS in your receive community now? I understood. Nowadays.
Nowadays, we have some cases of SARS-CoV and GBS presentation after 2 or 3 weeks of the infection. And I think so. We have no cases registered with the variant of the first identification of SARS-CoV. But we have now some cases presented with SARS-CoV and GBS.
Okay,
if we look around the world, Lucia, it's Hugh Willison here. There are many different infections which cause GBS, and of course there's been this great interest in COVID-19 and GBS. Are you saying that you've seen a few cases, or and do you think this is at the same kind of frequency that you saw with Zika, or do you think it is less common a complication of COVID-19?
It's an amazing thing because when we are in a Zika outbreak, we realize that there are a very amount of cases related to Zika and GBS. But nowadays we are comparing the cases. It's not so strong as we saw during Zika outbreak. It's less than this. I think there is maybe during the year, we realized that related to SARS-CoV, we don't see more than 5 cases.
Yes, that's an interesting remark, Lucia. We've, Professor Lan in London, and Tom's been involved in this surveillance as well, have not seen a large number of cases of GBS with COVID-19. And maybe Sonia can comment on the experience from IGOS COVID-19 register, where again, it doesn't seem to be anything like the frequency that we saw with Zika.
Well,
So
thank you.
Experience is rather similar.
That's a nice lead into the next session, which is going to be on GBS, and Sonia will be talking then. But just before we move to that, there is one question come from Dr. Vasconcelos, who asks, it's known until this moment that Zika infection may bring some problems to the urinary tract in children. Did your group find neurogenic bladder problems in patients with Zika or chikungunya too? That's from Dr. Vasconcelos in the Hospital de Restauration. Lucia, if you want to answer that, thanks.
I can't hear well this question, please, Tom.
So the question is about urinary tract problems in children, and Zika causes neurogenic bladder in children, but did you find this in adults? Did they have bladder problems through Zika or chikungunya infection?
No, nowadays we have, we are preparing the cases that we have from the pediatric ward, and we have no data now that we consider as an important point that we have to take and to show in this moment. And but maybe the cases from the pediatric ward is the behavior of the children is different from the adult, and maybe we have some differences also if we study these cases genetically and with immunological aspects or neuroimmunological aspects. Maybe if we have support, maybe we do this sort of evaluation in this, trying to compare both groups.
Great. Well, thank you, Lucia.
Thank you, Tom. And welcome again to all here in this great symposium. It's great to see you all. We would like to move to the next session, which will be dedicated to the Guillain-Barre syndrome, the many research projects that we have done collectively. And I first would like to introduce to you Sonja Leonard. She's a student at Erasmus MC in Rotterdam, the Netherlands, and she's about to finish her thesis on the association between Zika and the Guillain-Barre syndrome and with other infections and especially pandemics. So without further ado, Sonja, can you give your lecture?
Hi, everybody. Let me just share my screen. Hi, everyone. It's a pleasure to be invited to talk here to you about Guillain-Barre syndrome in relation to Zika virus and also in relation to other pandemics. I realize that many of you on the webinar now may not be neurologists, and some of you may not know what Guillain-Barre syndrome or GBS is. So GBS is a severe neurological condition that can cause paralysis, and it is caused by inflammation of the peripheral nerves. It's a rare disease which occurs in about 1 to 2 per 100,000 person years, and it can be triggered by infections. About 20% of GBS patients are admitted to the intensive care unit because of involvement of the respiratory tract muscles, and 2 to 12% of GBS patients die, depending on the care available, which is mostly due to complications at the ICU, such as pneumonia or involvement of the autonomic nervous system. So GBS has been associated in previous studies with different types of infection. The 5 infections listed on this slide have been associated with GBS in case control studies. And the most important one is the Campylobacter jejuni infection, which causes a gastrointestinal infection. It's a bacterium that occurs in about 30% of GBS patients. So before talking to you about the relation between Zika virus and GBS, I wanted to take you back to the timeline of the Zika virus pandemic. So Zika virus was first discovered in 1947 in the Zika forest in Uganda. And this is why the virus is called Zika. And then in the next about 60 years, nothing really happened. So it didn't cause any outbreaks. That only happened in 2007 on the Yap Island in Micronesia. And then again, 6 years later on the island of French Polynesia in 2013. But many of you will first have heard of Zika during the big pandemic, of course, in Brazil in early 2015, that then spread to other countries in Latin America and also across the world. But even during the French Polynesia outbreak in 2013, a relation with occurrence of GBS was found. So in this publication in The Lancet, you can see in the orange bars the number of Zika cases, and in the red bars the number of GBS cases. So you can clearly see that a rise in GBS cases was found during this first, or one of these first outbreaks of Zika virus. And during the pandemic in Latin America, similar findings have been found. So here's a study that of 7 countries in Latin America, also showing in the yellow bars the GBS patients that increased during the Zika virus outbreak, that is shown in the green bars. And in total, a temporal association between Zika virus incidence increase and a GBS incidence increase has been found in 23 countries. And evidence of an association has been found in at least 7 case control studies across 6 different countries. And the risk of getting GBS after a Zika virus infection has been estimated at 2 GBS cases per 10,000 Zika virus cases, which is about 10 times as high as the normal incidence of GBS. So the reason that I or we at Erasmus MC got involved in researching the relation between GBS and Zika is because of IGOS, the International GBS Outcome Study. So this is the largest ongoing cohort study on Guillain-Barre Syndrome, which was set up by Professor Jacobs in 2012. And over the past years, more than 160 hospitals have participated in the study across 22 countries, and about 2,000 GBS patients have been included. So we were asked if we could use the infrastructure of IGOS to also research the relation between Zika and GBS. So this is what we did. We've shared the protocol of IGOS with several other research groups that were involved in studying the relation between Zika and GBS, including the NIAS group in Colombia and Sing Health in several countries in Southeast Asia. And we also set up a case control study that was based on IGOS and was specifically developed to study the relation between Zika and GBS, which was called IGOS Zika, and has been operative in several cities across Brazil, Argentina, and Malaysia. So I wanted to highlight a few of the projects that we were involved in. And the first one is the project that was set up by Dr. Lucia Brito, who just gave a talk. And this was a study that she set up with her group in her hospital in Recife in Northeast Brazil. You can see on the map the little red state, that is the Pernambuco state where Recife is. And she found that in the end of December 2014, an increase in the amount of GBS cases was found, and also in 2015 and 16. And during these times, of course, the Zika epidemic occurred, but also chikungunya epidemic, as you can see in this figure. So she set up the cohort study, including all GBS cases that had preceding symptoms of an arbovirus infection. And in total, 71 cases were included, and 48 of them, so 68%, had evidence of a recent arbovirus infection. Most of them had Zika virus infection, but also 11% had a chikungunya infection, and 20% had both evidence of a Zika and chikungunya infection, which is of course a very interesting finding. Most of these patients had a classic type of GBS because there are several different phenotypes of the disease, but these patients had a classic variant, which is the sensory motor demyelinating variant of GBS. And interestingly, we found that the disease course in patients with evidence of both the Zika and a chikungunya infection was worse. We also wanted to look at, this is something that was already highlighted just now in the conversation, but we also wanted to look at what has been found in relation to GBS related to Zika in other publications. So we did a systematic review and meta-analysis of all the studies that have been published on GBS cases in relation to Zika virus. And in this study, we included 35 studies reporting on more than 600 GBS patients. And what we found was most of these patients had the time between infectious and neurological symptoms was, the median was between 5 and 12 days, which is an important finding because in the beginning of the Zika virus epidemic, it was thought that maybe Zika virus related GBS was very different from the classic type of GBS or from GBS related to other infections, because the time between the onset of infectious symptoms or symptoms of Zika virus infection was shorter than was expected based on other cases of GBS. And so short that it was thought that maybe it was due to a direct infection and not a classic post-infectious disease. However, in this study, we found that this time, so about a week in most cases, is actually more fitting with a post-infectious disease mechanism and also very similar to GBS after other types of infection. And again, we found that most cases had a sensory motor demyelinating variant of GBS, so a classic type of GBS. As already highlighted, we found a high rate of ICU admission, about 50%, and mechanical ventilation, which is higher than expected based on previous literature on GBS after other infections. And the third study I wanted to highlight is that so we knew that there was an increase in GBS cases during the Zika virus pandemic in Brazil, but we did not yet know what the impact of that was on the management of GBS. So we did a survey study amongst all neurologists working in Brazil, and eventually 171 neurologists participated in the study. And we asked them what the most important limitations were in managing GBS. And so 60% of neurologists indicated that they found any limitation in the performance of nerve conduction studies. 55% had some problems in referring patients to the ICU, and 30% had problems referring patients to rehabilitation units. Furthermore, most neurologists did not use a protocol to treat GBS, which makes sense because at that time there was no national guideline for GBS treatment or management. And also the treatment practice varied. So also based on this study, we got together with a big group of international GBS experts to make an international consensus guideline, because not only was there no national guideline for GBS in Brazil, but there was also no international guideline for the diagnosis and treatment of GBS. So we got together with a large group of people from different countries across the world, as you can see in purple on the map. And we made a simple guideline, which has a 10 steps approach that was also developed to be able to be applicable in all different health settings. And to improve the dissemination of these guidelines, we also made a translation to Portuguese, which was published in a national Brazilian journal, and are preparing translations to Spanish and Chinese as well. Furthermore, we collaborated with READY and the Global Health Network to also make an online tool, which is accessible to everybody based on these 10 steps guideline. So as I said in the beginning of the presentation, I was going to talk not only about Zika, but also about other epidemics, because Zika is not the first epidemic of an infectious disease associated with outbreaks of GBS. These are all different, and the timeline, different outbreaks of GBS and the relation with the different pathogens. And it's probably also not going to be the last outbreak related to last GBS outbreak. So one of the examples of this is that in 2019, there was a huge outbreak of GBS in Peru, so big that they even declared it a health emergency. And as you can see on this figure, you can understand why they called it a health emergency, because in the blue line, you can see the number of GBS cases in 2018, and in the orange line, the number of cases in 2019. So this was a huge increase. And of course, initially it was thought that this might be due to Zika, because it was at the end of the epidemic of Zika and in a Latin American country. But in collaboration with a neurologist from Peru, Dr. Ramos, we actually discovered that it was not due to Zika or other arboviruses, but due to the bacterium Campylobacter jejuni. And now, of course, we're in a new pandemic, COVID-19, and already several cases have been reported in case series and small cohort studies that suggest that there might be a relation between SARS-CoV-2 and GBS. Recently, however, a study from the UK, an epidemiological study, finds no association between COVID-19 and GBS, and even found that the number of GBS cases decreased during the COVID-19 outbreak, or pandemic, I must say. And Dr. Willison also highlighted that we are also investigating this currently in the EIGL study. And here we find that there are some GBS cases with recent COVID-19 infection, but we're not sure if this is really an association or a coincidental finding. So I want to conclude with a slide that highlights the legacy of Zika Plan. So Zika Plan has enabled us to increase our understanding of the association between Zika virus and other arboviruses and GBS, and also the impact of arboviruses on the management of GBS across the world. We've been able to increase our international network of research groups and enhance our response to future outbreaks. And we have been able to make an international clinical guideline for GBS and online tools to help clinicians all around the world to diagnose and manage these patients in a good way. So here I want to end with my most important slide. Everything that I just talked about was work that was done with huge groups of people, and I want to thank them very much for a great collaboration in the past years. Thank you.
Thank you, Sonia. I'll clap on everybody's behalf.
Okay, thank you, Sonia. This was a very clear presentation and a good overview on all the research that has been done. Thank you as well for the hard work, and with you also the other people that supported you and collaborated in these studies. I'm not sure if the chat function is working really well, but are there any questions for Sonia?
Can I ask a question about Sonia, the study from Peru? How, you know, a lot of this program is about sort of networks and preparing for the future. Although it turned out not to be Zika, it turned out to be Campylobacter. Were there any kind of benefits from having the network involvement from, you know, did Zika Plan contribute in any way, laying any of the groundwork for that kind of study?
Yes, I think so. Dr. Ramos, I think, initially contacted Dr. Pardo, who it was part of the, amongst others, of the NIAS group that was investigating the neurological complications of the arbovirus infections in Colombia. And as far as I know, we were not collaborating yet with Dr. Pardo before the Zika Plan started, because we were all part of Zika Plan. So we were very quickly, we could sort of link to each other and help each other in connecting the right people really to investigate this in a quick way. So I think that especially sort of the connectivity between all these different investigators, Zika plan has really played a crucial part.
And you also mentioned the obviously the COVID-19 and the data on that, and Guillain-Barre syndrome, and maybe this is a chance to open it to you and to Hugh and to Bart, particularly with this paper that you mentioned that looked at the UK epidemiological data, and those data suggest that GBS, rather than increasing during the pandemic, GBS has gone down overall in the UK, and but of course that's presumably because lots of infectious causes are less prevalent because of all the lockdowns. Do you think it's still possible, and this is a question for all of you, is it still possible that GBS is actually a trigger, COVID is a trigger of GBS, even if it's not given us this high epidemiological signal? Or are those cases where we've seen COVID followed by GBS, is the COVID just a coincidence, or could it be a trigger, even if it's not a very big trigger? Who'd like to have a go at that?
Yeah, I think if it's a trigger, it's a rare trigger, honestly, because I mean, at this time we've had millions and millions of people who've had COVID-19. So even if you would say like the number of Campylobacter cases or the number of CMV cases that might cause GBS have gone down drastically, and still you would expect not to see a decrease, but some kind of increase, I think, in incidence of GBS, or at least a stable amount of cases. But I think that at this point we cannot really exclude that it might be one of these rare causes of the disease, and that some of these cases that have been reported are truly cases that are associated with GBS. But I don't know what Dr. Willison thinks and Professor Jacob.
I think, yes, it's Hugh Willison here. I think you've put that very well, Sonia, and I think Tom's raised a very important point. And, you know, when is an association high enough to be, you know, clinically relevant or biologically plausible, I think is a very, almost a philosophical question. One of the things you might highlight, Sonia, is your experience from the IGOS cohort, in which in some cases you've seen dual infections with organisms which are known to trigger GBS. And so I think the assumption that the COVID-19 cases associated with GBS have only had COVID-19 and not other triggers as well is a difficult one to be certain about.
Okay, I think if there are no more questions, we probably better keep moving on. But Sonia, thank you for that part.
You're welcome.
Thank you as well, also for the discussion. I would like to move on to the next speaker, Professor Hugh Willison from Glasgow University. I'm having the privilege of working together with Professor Willison already for a very long time, even when I was a PhD student. We had a lot of fun, and I am very honored to present to you, Professor Willison, with an overview on the GBS pathophysiology. Hugh.
Yes, good afternoon, good morning, good evening, everybody around the world. It's a real pleasure to be here today. I was involved with Annelies in setting up this Zika plan program, as you know, and my brief was to run work package 4, which really covers the pathophysiology of neuro-Zika in its different forms. And a lot of people were involved in this, and you're going to hear some of these studies in a few minutes from my co-investigator in the University of Glasgow, Dr. Julia Edgar. I'm really going to stick to some of the sort of science behind Guillain-Barre syndrome and what we were looking for within the Zika plan program. And I think, as has been alluded to earlier, one of the first things that we really had to try to understand was whether Zika GBS was due to direct infection of the nervous system, of the peripheral nervous system, or whether it was a para-infectious or post-infectious autoimmune response. And dealing with Zika, which is such a neurotropic virus, I think it is completely reasonable to understand that it might also infect the peripheral nervous system and thus drive a direct neurotoxicity of peripheral nerve through infection, as well as the possibility of post-infectious autoimmunity. And Julia is going to tell you about some of the direct infection studies that we conducted later, and I'm going to really stick to this issue of post-infectious autoimmunity as outlined in this wee figure here. And it's a complicated subject because, of course, as we heard from other speakers, including Sonia, Zika, chikungunya, and dengue are all circulating at the same time, and we're not quite clear, you know, whether GBS might be solely driven by one or all of these viruses, and indeed whether it might be some sort of cooperation between a number of them. And gathering cohorts of patients and clinical samples that are acutely timed in the context of the onset of the disease is also a challenging issue in its own right. The real model that we all think about when we think about Guillain-Barre syndrome, and I've illustrated two known causal infections of Guillain-Barre in this cartoon here, one of them being C. jejuni and the other being Zika virus. So it seems as though an infection drives an antibody and a T cell response to that infection in the immune system in the normal way, but that somehow molecular determinants on the surface of the infection, here illustrated for C. jejuni and putatively for components of Zika virus, trigger an immune response, which through a process we call molecular mimicry goes on to lead to cross-reactivity with targets in the peripheral nervous system, and therefore the onset of diseases like Guillain-Barre syndrome. And this pathway of infection leading to an immune response, which then traffics into peripheral nerve and acts neurotoxically on peripheral nerve, is very well established for C. jejuni infection. And of course, when we saw Zika GBS, we wondered whether a similar pathway to that we see with C. jejuni was also arising in the context of Zika GBS. And as Sonia alluded to earlier, one of the first opportunities to look at that really came in 2014 when my laboratory in Glasgow was asked by the Pasteur Institute and their colleagues in French Polynesia to look at the serum samples from these patients in the Zika GBS epidemic that occurred in French Polynesia at the time. And they had done some preliminary studies looking for the main antibody targets that we see in Guillain-Barre syndrome, and these are called gangliosides or glycolipids. And from their preliminary analysis, they had identified some autoantibodies to different glycolipids in these populations of Zika GBS patients, which they thought might be relevant. And that's really where we were asked to step in and try and confirm these results and also start investigating wider cohorts. So we've been involved in this for, you know, at least 5 years, if not going on 7 or 8. And it has led to the most fantastic collection of collaborations around the world. Recife, Lucia has talked to you about. You've heard a little bit about the NEAS network in Colombia that we've been involved with, the French Polynesia. But there are also other groups, for example, in Puerto Rico that we've been involved with as well. And it has been the most fantastic collection of researchers and research opportunities in which to address these questions. So we've received samples in our laboratory for looking for this glycolipid antibody signature from pretty much all of these groups. And I'll just share with you a couple of things that we found. Now, these may look rather complicated. They're actually much simpler than they appear to be. And across the top are all the different glycolipids that we've looked at. And down here are all the different clinical groups, and each horizontal line going the whole way across is a single patient. So that's about 30 patients there, and that's about half a dozen or so. And the hot spots in red show an intense antibody activity to a particular target, and the black spots show completely the opposite, and the rainbow in between. And these have been sorted using statistical methodology called heat mapping. And this is the Kali cohort from the NAAS network, and you can see that in that there's a very wide spread of this type of antibody reactivity to particular targets, which occurs across all the groups, not just the Guillain-Barre groups, but also the dengue, the Zika convalescent and acute groups. And this is a kind of background reactivity which doesn't segregate with Guillain-Barre syndrome. There was a suggestion that some of the cases might have looked a little bit like the French Polynesian samples, but nothing really jumped out from this cohort at us. And we then went on to look at the cohort from Lucia and from the Recife network. And again, it was a disappointing result in the sense that we didn't find a clear glycolipid antibody signature, but it was an important result in the sense that it was clearly very different from what we might usually see in GBS. And to show you what we might usually see, I'll point you to the Peruvian outbreak, which was this collaboration with Ana Ramos through Carlos that Sonia mentioned before. And this is the data from the Peruvian GBS outbreak, which was initially possibly suspected to be due to Zika. And you can see that it's completely different, because this is the control group here, where there is really very little signal indeed. But in the Peruvian GBS cases, you see this massive clustering of antibody responses to key Guillain-Barre driving glycolipids, and similarly these groups here. And when you add all of these up, the sensitivity of this finding is approaching 90%. So this is an extremely different kind of heat map from the ones that we're seeing in Zika GBS. And what this really telling us is that we know the infectious drivers of Guillain-Barre syndrome vary hugely in different outbreaks around the world. And in contrast to other types of GBS, and particularly C. jejuni GBS, this typical anti-glycolipid antibody signature that we see in Campylobacter GBS is not evident in Zika GBS. And in a way, this allows us to look, when we see an antibody biomarker to a ganglioside, it rather suggests that that indeed is not due to Zika GBS. And we know that in some of the cohorts that we've looked at of apparent Zika GBS, we have seen this ganglioside antibody signature. And it certainly suggests to me that perhaps those patients also had, for example, a recent Campylobacter infection or another infection that drives GBS, and comes back to the point that I raised earlier about multiple infections potentially confounding one's interpretation of these studies. So having not found the key antibody to be a glycolipid, we then went on to start to look for other targets, and through collaborations with Simon Rinaldi and Luis Querol in Oxford and Barcelona, have been moving this forward. And I'll just share with you finally one slide which Simon Rinaldi sent me from his group, which is really remarkable. And here what they've done is they've taken serum samples from patients with Zika GBS and applied them to living nerves in culture to see whether any antibodies in those serum samples might actually bind to peripheral nerve. And you can see that they do. I mean, here's a Zika GBS case where the antibody in the blood is binding to a key part of the nerve at the node of Ranvier, in fact, at the edge of the node of Ranvier, called the paranode. And this is a very significant finding indeed. And here's another patient in which the staining is much more widely distributed, but also includes the nodal gap itself. And when they add complement, which is a lytic blood component, to these cultures, the whole of the myelin in the culture disappears in a way you'd expect to see with Zika GBS. In a way you'd expect to see in patients with Guillain-Barre syndrome. And so there is no doubt that some Zika GBS cases do harbor neurotoxic antibodies. And through different approaches like immunoprecipitation with mass spectrometry, they're pulling down targets, which are shown down here in the bottom right-hand corner, which could be related to the disease as antibody targets and need validating in further studies. So I think that what this set of studies has shown us is that by careful searching, one can find autoantibody biomarkers for Zika GBS, which will help in case definition and diagnosis in the future. And it just leaves me to mention a couple of people in my laboratory who run the glycoarray facility, notably Susan Halstead and Dawn Gourlay, who have literally, under Zika plan, examined thousands of samples and produced some really interesting data, which is in part published and continues to be published. And we're also very closely networked into the IGOS database, and Sue and Dawn have just finished the glycolipid antibody screening now for over 1,000 patients in the IGOS database, much of which has been generated through the fantastic community that we have with Zika Plan and associated groups. So that's all I have to say, and thank you very much for listening.
Thank you very much, you. Very clear story. Let's give an applaud. So in the chat box, there's one question from Lida Osario, and she asks, what is Zika doing in the CSF?
Well, if it's sort of thinking two steps ahead and saying, do I think that may be in some way driving Zika GBS? I don't think so particularly. That's not, I mean, we think of GBS as really being a peripheral immune response in a target organ in the periphery or in peripheral lymph nodes that spills over into the nerves and into the nerve roots and possibly into the CSF rather than a direct infection. There's no reason why Zika shouldn't penetrate the brain. We know it gets into the fetal brain. We know it gets into the adult brain. I mean, Tom and colleagues will no doubt tell us about Zika encephalitis. I think even if a patient has Zika GBS, there's no reason why they shouldn't also potentially, as a post-infectious autoimmune disease, there's no reason why they also shouldn't potentially have direct Zika infection of the central nervous system at the same time. So a rather open question and a rather open answer, but if the questioner wants to ask me something a bit more specifically, then I'm happy to have a shot at it.
Maybe I can ask you something quite specific. So, I mean, those images from the Campylobacter were striking.
Yes.
And, you know, the fact I guess one question is, how much would we see that with other causes of GBS, like, say, CMV? And then the fact that we're not seeing a pattern with Zika, does that mean that Zika is causing GBS via a range of different approaches, or does it just mean that are there no anti-glycolipid antibodies? Is it antibodies against some other nerve component? You know, how do we make sense of it?
Tom, as usual, you asked the $1 million question, and we just don't know. I mean, in general terms, bacterially driven GBS like Haemophilus, Mycoplasma, Campylobacter have been much more strongly associated with anti-glycolipid antibodies, and it has been much easier to find them. In contrast, virally driven GBS like hepatitis E, CMV, Zika, it's been much harder to find the relevant putative autoantibody. It still could be a glycolipid, but not the normal sort of glycolipid that we think about, but some odd glycolipid, perhaps even one which is human specific. I mean, there are certain glycolipids which really only occur in humans, and they're extremely difficult to investigate. It could be a cluster of glycolipids carried in the viral envelope that we haven't been able to sort of reconstruct, or it could be something completely different, like some membrane protein, or it could be nothing to do with direct antibody-mediated autoimmunity, but a much more complicated immunological mechanism which we haven't even thought of. And it is true to say those questions are still very open, and I think Zika has really helped us to, you know, illuminate that area.
We're running into the, we're just about butting on coffee, but Annalise has just, she looks like she's just come off the ski slopes and is sitting outside her ski chalet there and is going to ask the final question or make the final comment.
Yes, well, thank you, Tom, and thank you, Hugh. So basically, with a not yet well-defined receptor or mediator, there's also no therapeutic option in the moment. Is that a correct conclusion?
No, well, the first part of what you say is correct. The second part is a little bit more general than that, and that we treat all Guillain-Barre syndrome rather the same, with the presumption that the mechanism, even if the precise molecular receptor isn't known, that the downstream pathways are the same in different patients. And one gets this information from electrophysiology and the clinical course and from various other things. So the treatment is the same as normal Guillain-Barre syndrome, which is intravenous immunoglobulin and plasma exchange therapy. And in fact, in Zika GBS, and maybe the clinicians can correct me or step in fact, most were treated with one of those treatments where it was available, and many of them have done extremely well and recovered very well. So no, I don't think it introduces a kind of nihilistic approach to treatment at all.
Can I ask a very last question of Bart, our session chair? But we'll have to keep the answer brief, but it's a good question that's come in from the chat. Should we be using anti-ganglioside antibodies as part of the routine testing to help us diagnose GBS, or is our clinical acumen good enough and we should just leave these tests for the fascination of Professor Willison and his colleagues?
Well, in a short answer, because it's a rather difficult question indeed, I think in general, there is not really an added value of testing ganglioside antibodies for the diagnosis of GBS because it is lacking, let's say, sensitivity. And there's a big issue with the techniques that are used to test these antibodies, and that influence the result, of course. But there's a lot of new developments. New antibodies are discovered. And I can imagine that in the future, we will have a kind of set of antibodies that is playing a role in the diagnostics. And I think that's already becoming more clear for antibodies to GQ and B, which are highly specific for the Miller-Fisher variant of Guillain-Barre syndrome. And we are using that test in some clinical situation already, but more research needs to be done.
Okay.
First, thank you, Tom Solomon, for the invitation. And as you said, I'm sharing this presentation with Dr. Demócrito Miranda, who is the coordinator of the MURG pediatric cohort. He has kindly agreed to participate in this panel. So please address all the difficult questions to him at the end, if you may. So what I can show you is that what you saw before, that in Pernambuco state, Brazil, there were dengue, chikungunya virus, and Zika that were circulating. Zika virus had just been introduced in the country, and we had no system, official register system for it. So we used to call it dengue-like disease. So you can see here, I mean, the amount, there was an outbreak of dengue-like disease, followed shortly by Guillain-Barre Syndrome, and 6 months after, a huge outbreak of microcephaly, neonates with microcephaly. So the orange line that was clustered in space and time. So the evidence of Zika viral infection related to GBS patients regionally was the first hint, the first signal that Dr. Carlos Brito used, I mean, to raise the hypothesis of a possible brain damage associated with Zika exposure during pregnancy. We must remember that at that time, there were no report association between Zika virus infection during pregnancy and birth defect, not even the outbreaks, the previous outbreak in French Polynesia. Actually, Zika virus was considered to cause a mild disease and was really considered a public health threat. So we had a public health problem. Large numbers of newborns with severe microcephaly of unknown cause, space and time cluster that became a national health, international and national, let's say, concern emergency. And Zika Plan is all about this effort to understand this new disease, that's congenital Zika syndrome. So as far as I can remember, this was the special section of Zika in the first journal that published a special section for Zika. And there were 2 papers I would like to highlight. One was the editorial entitled Zika, the Tragedy and the Opportunities by Dr. Laura Rodrigues from London School, that has been part of Merck Task Force since the beginning, 2015. And Dr. Rodrigues just wrote about this unprecedented public health situation, what she called the possible first congenital transmission of a vector-borne virus in human, and possibly the first sexual transmission of vector-borne virus. So the second paper by Dr. Democritus showed that microcephaly, together what I would say major congenital birth defects. Here's a picture of a newborn baby in the ICU with arthrogryposis of leg and arm. So this was a spectrum of severity of the disease. But what I find most interesting in his paper is that the table where he placed Zika with the torsion infections. So here, for the first time for us epidemiologists, there was a striking different mode of transmission. For the first time, within the congenital transmissions, we had an arthropod and sexual virus transmission. And this was really considered dangerous and a threat, not only for Americas, but also for other parts of the world or for the world as a whole. Okay. So what I can say, other important, let's say, first papers in the beginning of 2016 is a large number of infants born with microcephaly. And here I would like just to call the attention that these newborns had kind of a distinct physical appearance. It was really not a new phenotype, but it was a rare event before the outbreak of Zika congenital infection. And this appearance is a result of a substantial loss of the brain volume, and contractures, hypertonia, irritability were noticed since the early stages or in the newborns. So I wouldn't dare describe here or to get into details of CT for many of the neurologists who are here attending. I think this panel, but I would remember and see all the papers about it, saying about thin cerebral cortex with subcortical calcification, and the words ventriculomegaly, lissencephaly being placed and being written in almost all of the papers talking about CT in newborns and later on. So I want to just to show the attention that the first case control study done by our group looked at possible risk factors for the increase in congenital microcephaly cases that were observed in Pernambuco between 2015 and 2016. Okay, we have to remember that at the beginning of the epidemic, many other hypotheses besides Zika infections were raised, like vaccine use, larvicides use, and drugs during pregnancy. So we had to screen newborns from 8 hospitals. We recruit 91 newborns with microcephaly and matched by controls with microcephaly. And we tested for Zika serology, CSF for the babies with microcephaly, and not for their controls, of course. And we just came out with a striking difference between the amount of babies with evidence of Zika infections between the 2 groups. But more important, I think, that the striking, say, very high odds ratio, that was the very strong odds ratio, that in the study, we could not found evidence of association of other risk factors. That was very important at the time, because at that time there was a big issue about if the rubella vaccine was causing this kind of microcephaly, or even if larvicides were the cause of this outbreak. So as far as I remember, this was one of first slides that was a democratic slides, considering that, well, if you have microcephaly, maybe microcephaly is only the tip of the iceberg. Because we have such a large structural brain damages, it would be expected early epilepsy, visual impairment, impairment of neurodevelopment, dysphagia, and all of the things were found and described during the time that we had the Zika plan support. Hearing impairment just was something that was thought to be important, because it was kind of thinking about similarity with cytomegalovirus, but came out not to be such important, or not, I mean, very common among the microcephalic cases and other anomalies. We would say here, we didn't put the visual impairment is something described, and it was very important, saying like there were anomalies of the anterior and posterior eye, and microcephaly, coloboma, optical, let's say, hypoplasia, macular scanning, and so on. And there were many papers written by our colleagues, Dr. Ventura, that were very important and partner during this. So if we see all this spectrum, what we could expect that we would need a multidisciplinary experts, let's say, like pediatric infectious disease, developmental pediatrics, neurology, ophthalmology, audiology, speech therapies, and you name it, urologists, and so on. So you might expect that not all these expertise, I mean, are available, especially in, let's say, in middle-income countries, and probably not available for the population, the vulnerable population. So I would think that there was a big effort to join all this research to make what we call in Portuguese mutirão, is joint effort, one day of follow-up, well organized. We developed protocols where we could include many of the specialists to follow up these children in a very specific date. So for this part of the work, for the cohort and the follow-up of this clinical cohort, I would say that was the Zika plan support was really very, very important. I mean, I think that most of this effort couldn't be done without the support, not only financial support, but also the network that was built during the Zika plan network. So if we go here, I want just to say, what are the sources of this pediatric course that have been assisted and evaluated and follow up by this team? So we have here from the early beginning of the epidemic, about 195 children that were born during the outbreaks. So they were seen from the, let's say, for the clinics. We had 80 children from the case control studies where it had been really evaluated at birth and had all the prenatal exams done. And now we could count what with children that were born from pregnant women cohort that were retrieved from the surveillance system from Pernambuco State. So this is very interesting because we were having a possibility to follow the pairs of mother and children from a large group of individuals. And then, very importantly, there was a CIP study protocol where the studies control groups, the neonates from this group of pregnant women are taking, let's say, as a population control. As you know, epidemiologists always think about designs, but we always think in the designs to have a control group where we can compare all the diverse outcomes. So for all this preparation here to develop a comprehensive clinical laboratory imaging assessment and put it into place, I have to acknowledge the efforts and persistence of Dr. Demócrito Miranda, who is the coordinator of the children's cohort studies, and also Dr. Ricardo Ximenes, who is the coordinator of the pregnant woman protocols. So here I want to say this was the last meeting of the mothers in Recife. So you can say like the motor deficit of children born with congenital microcephaly. Now, I was supposed to say about the legacy of it. So thinking about the legacy, I would say that one of the challenges and the legacy, I think, is the possibility to deliver healthcare attendance integrated with the research activities. And for this, I would like to thank the Zika plan. And the other one was to strengthen research capacity. And here I have to say that this one-day attendance like this mutirões could only be possible if we could integrate postgraduate students and experts together so they make this effort to assist the children within a protocol or developing a protocol, a systematic protocol. And I would like to emphasize also as a legacy, the long-lasting partnerships with policymakers, I would say locally, regional, national, and international. And it has been really a pleasure to be part of this large international Zika plan network. Before I just end, I would like to acknowledge the institution and the contributors from Brazilian institutions, from Secretary of Health, from Fundação Altino Ventura, London School, and our postgraduate programs. And now to say thank you very much. First to Annelies, that's the coordinator of the program, that's her profile in the Lancet. And I agree entirely what's said in her profile published in Lancet about her energy and what she drives people to work together. So applause to Annelies, and also to our dearest friend, Dr. Laura Rodrigues and Elizabeth Whitley, who are really our persons that we admire for their integrity, ethical, and hardworking with our group. Thank you very much for your attention, and be here for questions if there are any.
Thanks very much, Selena. That's fantastic. Please post questions or comments in English or Portuguese or Spanish. And we've got one coming from on the chat function. So recently there have been reports of potential interactions between pyriproxyfen, which I think is an insecticide, and Zika virus in CNS developmental anomalies in animal models. Of course, there was a big issue about, whether this was all due to insecticide usage. But the question is, could the use of pyriproxyfen in Recife explain the high impact of congenital Zika syndrome there compared to other areas of Brazil and Latin America? Have we finally answered this question about why Recife is different to everywhere else? And is it insecticides in addition to the virus?
Well, first, may I answer this question? Is Democrito here?
Democrito's there, yeah. So maybe if Democrito wants to...
But may I answer this question? Well, I can easily answer this question. Recife is not different from other parts of Brazil. If we take the prevalence of microcephaly, they're almost the same. I mean, they were very high and almost the same in most of the states of Brazil in 2016. So Recife is not an exception. Okay. And about pyriproxyfen, there is a publication that was, the first author is Dr. Maria de Fátima Militão, with ecologically. First, pyriproxyfen was not a larvicide used in the municipality of Recife. Okay, it was used in other municipalities. So we had here not an environmental problem, because this insecticide was not used specific in this area. And what we can say is that even if it's an animal model, there is no evidence in other sites, and it couldn't explain why we had so many cases of microcephaly in places there was no use of this larvicide, such as Colombia, travelers, and so on. So I think larvicide was very easy to rule out for us at the beginning, because there was no an ecological, let's say, correspondence between the areas where they use larvicides and the areas where there were this increase of prevalence of microcephaly.
Okay, thank you. Thanks very much. Democrito is sharing the screen there to help draw attention to that. I guess one other question is whether you feel now, so clearly you made the point, I thought you articulated it very well, that the microcephaly drew attention to the problem, and since then we've found lots of other congenital Zika syndromes. I mean, we're now several years out, but do you still feel that we are identifying problems in children who up till now were thought to be completely normal, but it's only now that they're getting into school that it's becoming apparent maybe that their cognitive functions are not as good as they would otherwise have been? Or maybe if I could put that another way, you could imagine that something like this virus, it could cause just to say a 10% shift in IQ of the whole population. And of course, you wouldn't know that. Every individual child, you would just think they're fine. They have a particular IQ, a particular intelligence level. But is there the possibility that you would see changes that you could only detect by looking at population averages that you might miss if you just looked at individual children?
Let's see if I can start answering, then Democrito can complement if he wants. Actually, where we have the screening tests, like say a suite, I mean, the screening tests for, let's say, multidimensional, like a motor, skill language, and things like that, they're very different and very deep. Children with microcephaly score very badly. I mean, you can even imagine by the brain damage. But the other children that were born in the same period, they screen it okay. And even with the Bale syndromes, they simply to screen okay. So actually, discussing before this presentation, we had the feeling that most of the spectrum is under the microcephaly and severe and moderate microcephaly. And the iceberg below, I mean, the ones who weren't damaged, who had structural brain damage, doesn't look like they have different scores in the Bale and things like this. So this is interesting up to now. So, but we need to have to follow more children. And that's why we're so, I mean, it's so important to have a prolonged follow-up and to have this population children from negative mothers from the same region, so you can compare in long terms. But it looks like all the spectrum is concentrated in that tip of the iceberg.
Okay, Democrito, do you have anything to add? Is there anything that we need to add that we've not covered yet?
Yeah, thank you. It's about the first part of your question. Is a few comments about the syndrome. What we are just thinking now is that maybe we can put in the name, in the nomination of syndrome, congenital Zika syndrome is that very typical cases with microcephaly and a lot of other complications and abnormalities that configure really a syndrome. And we can observe just based on the larger studies with cohort studies from mothers who were with Zika during pregnancy, we can see also a few number of children with isolated or combining 2 or 3 manifestations, but not configuring exactly a syndrome. So children, what we can say is that children without microcephaly we can, I don't know, name them as congenital Zika with isolated or combined symptoms, is a congenital disease, but not like a syndromic. And we can observe that there is another, also a spectrum of manifestations in children with microcephaly. Even children with microcephaly, there is a spectrum also. Since microcephaly without all of these conjunct of manifestations, or syndromic babies with microcephaly and all these manifestations and radiologic findings, etc.
Okay. Well, thank you. Thanks to both of you for what's really been a really important area of the overall Zika plan project. And we're now going to move on to Julia, who's going to give us some perspectives on some of these neuroinfectious problems from animal models. Julia Edgar from the University of Glasgow, who's sharing her screen as well, I think.
Yes.
So
thank you very much. Tom, can you hear me?
We can hear you. We can see your slides. We can't yet see you.
Yeah. I just realized that I didn't switch my camera on, and once I start sharing slides, I'm not sure how easy that is to do. Can I, start my video.
You could just stop your share. There you are. Yeah, we've got you. Brilliant.
I was trying to be smart by sharing my slides in advance. Okay, so thank you, and it's very nice to be here today talking to you about understanding neuroinfectious diseases using animal models. So what we have done in Glasgow and with collaborators elsewhere is that we have modeled nervous system infection in vitro, in cell cultures, and also in vivo. And we've mainly modeled the fetal infection and tried to understand the tropism and pathogenesis of Zika virus infection. Just as a brief reminder, if my slides will move on, neurogenesis happens early in embryonic development. So in humans, neurogenesis occurs largely during the first trimester. Soon after, yolk sac-derived myeloid cells enter the central nervous system and become the microglial cells, the brain's immune cells. And I've shown a representation of a microglial cell here. So these come from the embryonic yolk sac. They enter the brain relatively early on in neurodevelopment. And as I say, these are the main immune cells of the central nervous system. They're present in the parenchyma of the brain and spinal cord. Gliogenesis and myelination happens somewhat later. So in human development, myelination and gliogenesis, formation of astrocytes and oligodendrocytes, and the formation of myelin sheaths around axons begins later. So it begins in the second trimester. Most myelination really happens postnatally, during year 1 and 2 postnatally. So we've used, as I mentioned, cell cultures and in vivo models to mimic this here, different stages of development, early development and later development, and indeed adulthood. As Hugh mentioned to you earlier, we looked also at direct infection in the peripheral nervous system, but since we found little evidence of direct infection of Zika virus in our peripheral nervous system myelinating cell cultures, I'm not going to talk too much about that. The focus today will be on the central nervous system. So we began our studies using a myelinating cell culture system to model perinatal infection in the first instance, so infection of infants just before term, and later in a very recent publication from Verena Schultz et al., postnatal infection. We're very proud of this myelinating cell culture system that was developed here in Glasgow by a veterinary neurologist called Christine Thompson, because it has hugely reduced the number of animals that we use for the types of studies involving infection by viruses and other pathogens. It doesn't stop us using animals, but it informs the animal studies and hence reduces the number of animals that we use for these studies. So as I said to you, we infected these myelinating cell cultures with Zika virus, and we found that those infected both in terms of perinatal the cultures mimicking the perinatal period and those mimicking postnatal period, we found in all cases that the cells that were most susceptible to infection were glial cells, and particularly oligodendrocytes. So oligodendrocyte precursor cells shown here, astrocytes shown here, and mature oligodendrocytes shown here were all susceptible to infection. But the one that was most vulnerable to injury was the myelinating oligodendrocyte, the one shown on the top right here. And these red dots, if you like, or these puncta, represent degrading myelin sheaths. So our conclusion from this was that post-neurogenesis, neurons are relatively refractory to infection. We found very few neurons infected with Zika virus. Glial cells are susceptible, and the oligodendrocyte in particular is susceptible to, is vulnerable to injury. And just to remind you, we saw very little evidence of direct infection in the peripheral nervous system. So soon after that, or around 2020, last year, studies were published demonstrating that children, congenitally infected children who were born completely asymptomatic went on to show neurodevelopmental abnormalities. And in some cases, so there are a number of these studies here. I hope I'm not contradicting anything Selena just told you. There are a number of these studies, and the picture I've shown here is from Pimentel et al. 2021. And what they show is that these children manifest sometimes transient neurodevelopmental delays, sometimes more long-term neurodevelopmental delays. So knowing what we knew from our in vitro studies, that led us to ask whether these neurodevelopmental delays in otherwise asymptomatic children, so children who were asymptomatic at birth, might be due to infection or injury of oligodendrocytes and of myelin. So to address this, we did indeed use an animal model this time, the FNR1 knockout mice that are lacking in type 1 interferon receptor. Here is the mock infected animal. Here it looks perfectly normal for a postnatal day 10 mouse. So we infected these mice around postnatal day 5, which is similar in the mouse in terms of what's happening with myelination to the perinatal period or preterm period in children. The Zika infected animals, on the other hand, did manifest neurological symptoms or signs, I should say. So there's a flaccid tail. This animal here has a flaccid tail. The belly rests on the floor here, and the hind limbs are not upright as they are in the mock infected animal. This animal here fails to be able to right itself. So it's lying on its back. It tries to right itself, but it is unable to do so. So these animals do develop neurological signs around 5 days after intraperitoneal infection. What we found, so similar to what we found in vitro, was that when we looked at the nervous system of these animals, there was evidence for cell death, so cleaved caspase 3 positive cells. This is the postnatal day 10 spinal cord, dorsal or posterior columns in human, ventral or anterior columns in human here, dorsal horn and ventral horn here. So we found evidence for cleaved caspase 3 positive cells indicating apoptosis around sites where we also observed Zika virus positive cells. And these Zika virus positive cells were predominantly located in the white matter. We found this consistently in both brain and spinal cord. When we looked more closely and used markers of cell type specificity, we found that at least some of these cells, some of these infected and apoptotic cells, expressed a marker of mature oligodendrocytes. To confirm this, we went to we used electron microscopy. This is a light microscopic image of a 1 micron thick resin section where you can see pycnotic nuclei, small condensed dark nuclei in the white matter. So these are myelinated axons here. The dark rings are the myelin and the pale structures in the center are the axons. When we looked more closely by electron microscopy, we could see evidence of dying cells interspersed with perfectly normal appearing healthy cells. Here's a healthy oligodendrocyte that was found pretty close to these other dying oligodendrocytes. Now I identified them as myelinating oligodendrocytes because you can see they're forming dark rings of myelin around the purple labeled axons here, and the nuclei look completely abnormal. There's swelling of the ER and the Golgi apparatus. So these in vivo studies fitted very nicely with what we had already shown in vitro, indicating that in the post-neurogenesis period, oligodendrocytes are particularly susceptible to infection and to injury. And that fitted quite nicely with our hypothesis that possibly these neurodevelopmental delays in children who appeared normal at birth could well reflect a myelin abnormality. Now, developmental myelination, deficits in developmental myelination, I should say, can catch up. So that may help explain the fact that some of these neurodevelopmental delays are only transient. The problem that might be encountered later is that it has been shown previously in an animal model whereby the oligodendrocytes were killed genetically, so specific killing of the oligodendrocyte. This is followed subsequently by loss of the myelin sheath and leads months later to an autoimmune type demyelination event. So it really indicates that even in asymptomatic children who may or may not have a transient myelination deficit, that one should be aware that these children may be susceptible later to autoimmune mediated demyelination. The other thing that I'm going to show you now, I'm going to show 2 slides from Suzanne Kaptein, and now she was more interested in what was happening in animal models during the period of neurogenesis. And so what Suzanne and colleagues from the Institute of Pasteur and other places showed very nicely in this very nice publication of Nature Communications, came out recently in 2021, that there is higher fetal pathogenicity for African Zika virus strains than Asian isolates or strains in mouse models of microcephaly. So unlike us, Suzanne infected these animals in the early embryonic period. So I think it was embryonic day 10, but Suzanne can correct me if I'm wrong about that. And what they found was that there was a higher fetal pathogenicity for the African Zika virus strains. The take-home message from their study is that the recent African Zika strains display a higher transmissibility in mosquitoes, this is an important observation, and higher lethality in both adult and fetal mice than their Asian counterparts. Now, Suzanne and colleagues conclude that this may be the reason why we see neurodevelopmental delays as a consequence of infection by the Asian strains, but not by the African ones, because of the high degree of embryonic lethality. So I hope I've convinced you that animal models and animal-derived cell cultures have several benefits, not least in terms of their flexibility. So it allows us to look at infections at different time points of development and in adulthood, using different transgenic animals, in reporter mice, FNR1 knockout mice, and so on. So a lot of flexibility in the system. In terms of a lasting legacy, well, our staff and students have received training in infection biology that they otherwise would not have. We have developed in vitro models for studying CNS and PNS infection that reduce the number of animals required for these studies by informing the subsequent animal experimentation. We have developed in vivo models, and we have made many new collaborations with people around the world. I want to highlight Susanna Lant, because when we wrote up the recent publication there on the in vivo infection, Susanna was extremely helpful in putting us together with other NeuroZika clinicians. So thank you particularly to Susanna for that. And a lot of the work was done by Verena Schultz. A lot of the experimental work I presented to you was done by Verena Schultz and others, of course. So just to thank you for your attention and for the funders, particularly Zika Plan, but also Medical Research Council and the Wellcome Trust.
Thank you, Julia. Lovely presentation. Wonderful slides. Okay, we have a bit of time for questions or comments. Hugh.
Yes, it's fantastically interesting, that, Julia. Do you think there's a case for sort of white matter, for, you know, detailed follow-up white matter MRI focused studies in a children's cohort? And can we ask any of our clinical colleagues whether such studies are taking place in a resource capable location?
Yeah, can I just answer briefly, and then I'll leave it to our clinical colleagues. I believe some MRI studies have been done on infants, Hugh. White matter can be difficult to image in infants. It can be difficult to see abnormalities by MRI. I understand this is not my area of expertise, because there is so little white matter or so little myelin present in infants. That said, I am aware of some MRI studies where children who appeared asymptomatic, clinically asymptomatic, did manifest white matter abnormalities by MRI. But let me ask,
one of the things would be to look serially over time, wouldn't it, Tom, in a sort of planned longitudinal cohort?
Yes, but I mean, I think the changes, you know, MRI are not great at picking up subtle changes on routine imaging. I don't know if if any of our pediatric or developmental colleagues has a comment, Selena or Democrito. It's possible, I guess, that you might see changes over time. Selena, what do you think about that? Following cohorts of kids longitudinally to see whether they have been, affected. I think the idea is that did infection, presumably, Julia, you're saying young children, so not congenital, but young children who got infected, could the virus have infected their myelinations in a way that we might see over time as they grow up?
Yeah, I think, well, there is a subset of children that were exposed, prenatally exposed. I think they had a pregnant woman exposed to Zika virus, and they had no signs of this phenotype typical, or no immediately, let's say, and they were submitted to an MRI. Up to now, they didn't find anything exceptional about it. There was about 30 cases that were done it. Remember that to do an MRI in a child that has no, immediately, let's say, medical purpose is something quite not usual, just for research purpose, to have an MRI of a child that wouldn't be. So, but what I think it's interesting, Julia, about your exposition, so we have to look at it. But as far as I know, there are several cohort studies doing Bailey in Brazil, and they have subgroups of children as controls that were exposed, that had, there were children born from pregnant women that were certainly exposed by Zika. And these children do not have any different from the control groups that were not exposed. And there were large cohorts in Bailey studies and so on. So, but we have to watch and to see the difference between those studies and see if they're mild or not. If we're missing something, and they have to have prolonged follow-up, that's for sure. And I really appreciate your presentation. It was very nice. I'm going to take a close look at the papers and to see how we can, figure out this difference, animal models and clinical practice and clinical cohorts. Thank you.
Thank you, Selena.
There's a few questions and comments come in, so we'll keep them short so we can keep moving. But Dr. Margarita has said that the follow-up study led by Dr. Mulkey et al. Concerning the Colombian cohort does include MRI follow-up at age 7. So that will be very interesting to look at that. There's a question from Sonia, actually was going to ask a question, I think, if she wants to come on. While she's coming on, I'll very quickly give you the question from Lida, which is how these animal model findings support therapeutic approaches. So, do these point to any particular treatments, Julia? Just a brief answer, I think.
So that's not really my area. Cholesterol supplementation, dietary cholesterol supplementation, for example, can help restore myelin.
Yeah. Hugh, do you want to add something as a clinician about whether any of these in vitro and mouse studies point to particular treatments, or is it a bit early for that, do you think?
I think it's too early, Tom, really. And it may be behavioral modification, schooling, etc., or just awareness of the problem as much as coming in with a specific, intervention right now.
Sonia, let's have your question and then we'll move on to the next session.
So Selena already showed us that there's a clinical overlap between, different microcephaly or congenital syndromes in relation to other pathogens. So I was wondering, for instance, with the torch pathogens, if there's also something known about similarities in the pathogenesis.
Oh, now that's a good question, Sonia, sorry. And I'm not able to answer it. I don't know if Hugh is able to help me out here.
I missed part of it. My internet broke up, so you'll have to ask it again.
I was wondering if with the torch pathogens and the congenital syndromes, if the pathogenical mechanism is similar as has Julia found now with the oligodendrocyte infection. Yeah, for instance, yeah.
Well, at a superficial level, probably yes, but the devil will be in the detail. I mean, I think Julia hasn't told you about some of the other work that's been done under work package 4, looking at the sort of intracellular molecular pathways that are mediating some of these events, and our collaborators in Sweden have also worked on this.
Okay.
And so I think it's likely to some extent to be virus specific.
I'm going to let Selena's come back on. She can say one sentence and then we'll move on, but I think she may have some thoughts on Torch.
I was just going to say that's a very good question, but what I want to point out that the torch, the other torch, there are multi-organ kind of, let's say, outcomes, adverse outcomes. You have a liver, spleen, you have skin lesions and so on. It's very different. When you look at congenital Zika syndrome baby, you look, if it's not extreme expectant, he seems all right, just with a very small head. And all the bad things start to happen after 6 months, like dysphagia, epilepsy, and so on and so on. So must be very difficult mechanism as far as I can look with my epidemiological hat. Okay. See you.
Thank you. Thanks for that. Thank you. And it's lovely to have this interaction of the clinical and epidemiology and also the basic science. So thank you all very much.
Tarum and myself, you were welcome to the last session on central nervous system and Zika virus. And to kick off, I will invite Susanna Land. She is an internal medicine trainee and clinical research fellow with the University of Liverpool Brain Infections Group. Susie will speak about her experience in Brazil researching neurological disease and Zika. Welcome, Susie.
Thanks, Lida. So yes, thanks for the introduction. Today I'm going to talk about the spectrum of neurological disease in Zika infection, and different from Sonia and Selena's talks, I'll focus more on central nervous system disease. So as Lida said, I'm from the University of Liverpool, which is in the UK. I'm part of the Brain Infections Group, which is led by Tom Solomon and works to reduce the global burden of neurological disease caused by infections in different ways, epidemiological and clinical studies, and also looking at things like disease mechanisms, diagnostics and treatments. And when we talk about nervous system disease, we talk about central nervous system disease. So that's things like inflammation of the lining of the brain, like meningitis, or of the brain itself, in encephalitis, and then you can have inflammation of the spinal cord secondary to viral infection, which we term myelitis. Looking at this figure on the right, you can see lots of blue nerves spreading out, and that's the peripheral nervous system. So as Hugh and Sonia have discussed, Guillain-Barre syndrome is a disease of the peripheral nerves. And why are we interested in nervous system disease? Well, there's a high morbidity and mortality. So for example, in Japanese encephalitis, which our group specializes in, there's a mortality of between 10 and 30%. It's an area which isn't which is under-researched globally with few effective treatments. So there are lots of opportunities for improving diagnosis and management in these patients. And there are lots of international collaborations that the group has. And since 2016, that list has also included Fiocruz in Recife and Rio, and which was spurred on by the emergence of Zika virus in the Americas. So we've had some introductions to Zika, but just to say that it's from the same family of viruses as viruses like Japanese encephalitis and dengue, which are known to be linked to neurological disease already. So whilst when Zika emerged, for many years, it was not recognized that it was linked to neurological disease. Perhaps it's not a complete surprise that there is evidence that it invades the central nervous system and causes neurological disease. It spreads from human to human by mosquitoes principally, but also, as Selena mentioned, from human to human directly, more rarely. And in most patients causes mild disease. However, since 2013, we have recognized that there is this link with neurological disease. And that was Guillain-Barre syndrome recognized first, which Sonia spoke about, and microcephaly and congenital Zika syndrome, which Democrito and Selina have spoken about at length in their great talk. And as Lucia Brito described at the beginning, she also recognized early on in the Zika pandemic, beginning in the Americas, that it wasn't just Guillain-Barre syndrome, but also other kinds of nervous system disease, such as meningitis, encephalitis, and also we tend to think of meningitis and encephalitis as sort of conditions that are linked to direct viral infection or occur around the time of infection because of early inflammatory responses. But also Lucia had seen in her patients with sort of later presentations of more immune-mediated nervous system disease that seemed a bit like MS, something called ADEM. So it's not just meningitis and encephalitis, but also other kinds of inflammatory disorders and spinal cord infections. And that these patients had a high level of sort of impact on their function from these diseases. So why was it that this association only really emerged in 2013? Well, there are lots of reasons, and it's difficult to pinpoint one, but there have been reports of sort of changes in the virus. And I think with COVID, it's interesting how probably everyone's much more literate about things like viral mutations, diagnosis of viral infection, and surveillance and epidemiological studies. So maybe whilst Zika was circulating in Africa and Asia, there were cases of neurological disease, but which weren't picked up on, particularly because we recognize that these are quite rare complications of Zika virus infection, but very serious rare complications. Perhaps we needed to have an outbreak that was as large as the one in the Americas, or in French Polynesia and then the Americas, to recognize these complications of Zika virus infection. And maybe it's also something to do with the population, for example, exposure to other kinds of viruses before, such as dengue or genetic differences. In terms of researching Zika, I think it's probably more challenging than it first seemed, or at least when I went into this field, than I first anticipated, because of course patients might develop neurological disease following Zika virus infection, but Zika, like COVID, does not always cause symptoms of viral infection in patients. So our patients that develop neurological disease following on from Zika virus infection are always symptomatic. And then when they develop neurological disease, they don't just look like one kind of syndrome. Often they develop many different syndromes, many different symptoms. So that's quite challenging to pick up on as a clinician. And then once you recognize that they have this neurological disease with or without preceding infection, the challenge of diagnosing that infection in a laboratory. So I think these challenges highlight just how impressive it is that Lucia Brito picked up on these things with her epidemiological approach to clinical practice. So what have we done specifically? Well, as our broader clinical neuro-Zika working group, which actually included most people who've spoken today, we had a number of aims, and I won't talk about all of them today, but I'll just focus on some of the clinical studies which we've done. So early on, Tom Solomon and Cristiani Suarez, who I think is joined today, as well as Ravi Mehta and Raquel and other people from Zika Plan, wrote up some early case reports, in addition to the case reports that Lucia Brito was producing in the north of the country. And Ravi, Raquel and Cristiani Suarez also then went on to publish this nice study, which was important in giving us an idea of the spectrum of neurological disease in Zika virus infection, which previously had been thought to be more limited to Guillain-Barre syndrome. And not just Zika virus infection, but also at that time, chikungunya emerged as a kind of cause of viral illness epidemics in Brazil. And in this study, it was clearly defined that chikungunya can also cause neurological disease of the central nervous system and possibly Guillain-Barre syndrome. In addition to those findings, it was also highlighted that patients presenting with neurological disease weren't just presenting with neurological disease and a Zika virus infection, but also sometimes had more than one infection with Zika and dengue or Zika and chikungunya. And as part of this work, the team established some clear neurological case definitions. So Ravi Mehta led on this. And I think it's important for research globally to have sort of standardized, accepted definitions of how we understand what these neurological patients look like for research and for clinical practice. Moving on from that Rio study, we had a larger study which was led by Lucia Brito in Recife, and rather than 22 patients, we had over 200 patients with neurological disease. And in those, we found that 148 had evidence of recent arboviral infection, and that was in an adult population in Hospital da Restauração in Recife. Of those 148 patients with arbovirus infection, 50, so just under a third, had infection with more than one virus. And as you can see here, they had infection of the kind of within the CSF, indicating infection of the central nervous system, which is in those darker central circles, as well as infection in the blood peripherally. These patients were not limited to just Guillain-Barre syndrome patients, but actually around a third had central nervous system disease, about a third had Guillain-Barre syndrome, and then there were also about 13 patients who had strokes. And we saw patients with Zika and neurological disease in 2015, as we might have expected, because that's when the Zika epidemic was happening. And then following on from that in 2016, chikungunya sort of joined and took over, and there were many patients presenting with just chikungunya and neurological disease, but also with Zika and chikungunya co-infection. So the key findings from that study, because we were able, with the numbers of patients we had, to compare what patients with chikungunya, what diseases they were developing compared to patients who had Zika virus infection. And we found that Zika virus patients do develop central nervous system disease, but they, compared to chikungunya, more frequently had Guillain-Barre syndrome. Whereas chikungunya patients more frequently developed central nervous system diseases such as encephalitis and myelitis. Importantly, in this study, we also found that infection with more than one virus was common and may also increase the risk of cerebrovascular disease and stroke. And I think the link between infection and stroke is something that has become increasingly pertinent and important in neurological infectious diseases research during the COVID pandemic, because we see that very frequently. Moving on from these studies, we then conducted a case control study across Brazil through 7 sites in Rio and 1 in Recife in children and adults. And we were looking to see if Zika was a true risk factor for neurological disease, and what, if so, what is the increased risk of neurological disease following infection with Zika, but also with chikungunya and with dengue. So we compared infection in cases and controls and tested those samples and recruited over 400 cases and 800 controls, and we're just completing the analysis of that work. But we think this will be really key research for public health policy planning, thinking about things like vaccination and other campaigns. We've used our Zika Plan network definitely, and research, learning from that research, and applied it to COVID. And I think it's had a huge impact, Zika Plan, in terms of kind of building up networks. Lena mentioned networks between healthcare researchers and policymakers, and I think that's very clear that Zika Plan had a big impact in that area. Obviously, we've developed our improved understanding of neurological disease in Zika and chikungunya. And the Zika Plan projects have led on to lots of additional funding and ongoing collaborative projects between the UK and Brazil and elsewhere. So thank you to everyone for all of your work. Obviously, I'm presenting the work on behalf of many different people, and I'm happy to take any questions.
Thank you, Susie. Maybe I kick off while the others come with more questions. It's for the people in endemic areas of Zika, how will you say them to be aware of potential central nervous system infection due to Zika or vector-borne diseases? For a patient, when are he aware, how he can be aware of this involvement and seek care, and what will be the reaction of the emergency doctor? Is that important for him to distinguish whether it was Zika or other infectious disease of the central nervous system?
Yeah, well, Definitely. You mean, is it important for the patient to kind of seek medical assistance for diagnostic purposes, just so we have that epidemiological data?
Yeah, he suspects he has Zika or chikungunya. And then he may expect at some point how many days after, what will be the landmark symptoms for him to suspect the central nervous system involvement after Zika or chikungunya or dengue.
Right. Well, in encephalitis, people typically develop things like seizures or reduced conscious level, and meningitis is more to do with kind of headaches, photophobia, neck stiffness, and I think what was clear from this cohort is those kinds of patients tend to develop neurological symptoms quite early on following on from infection. So I guess people should expect that that those symptoms might happen earlier on, although we did also see patients who develop, as I described, more immune-mediated sort of brain complications, and they can happen a bit later. Obviously with Guillain-Barre syndrome, that's more things like weakness and loss of sensation, or problems with speaking or breathing. But I think you've raised an important point, like how do you sort of educate the population about those things and have a broader public health impact rather than just characterizing these studies? How do you educate and engage people to seek help when they have those symptoms? And I think the other question you sort of mentioned about how important is it that we know that it's Zika versus any other viral cause of these neurological problems? Well, I think in terms of sort of diagnosis and treatment, although there aren't many treatments for Zika, well, there aren't treatments for Zika, chikungunya and dengue specifically, these patients can deteriorate quite quickly and need more intensive care support or, sort of intubation and ventilation. And obviously, if it's not Zika, chikungunya and dengue, and it's something like herpes simplex virus encephalitis, then we know that acyclovir can have a huge impact on morbidity and mortality, and people need to be treated with that early on. So, so it is, I think, very important that we have diagnostic data on these cases.
Thank you, Susie. I think, Selena, you wanted to ask a question? That you have your video on. Okay, sorry. Do we have any more questions? Carlos or Aaron?
This is Joe. I don't know if he's got a comment as well, if he's just ready for the next session.
Tom, I cannot hear you properly.
Maybe I'll just ask Susie one quick question. You mentioned the increased risk of stroke in patients who have dual infection. And of course, now in this COVID pandemic, we've seen quite a lot of stroke. Do you think there are more causes of infection precipitating stroke that perhaps have gone under the radar up till now?
Yeah, well, we know that HIV, for example, is something that's definitely linked to stroke. And there are observational studies on dengue and stroke, which I've seen. So yeah, probably I think it's not quite clear. I think probably the mechanism for different viruses is different. So for HIV, we know it's more of a vasculopathy, whereas for COVID, increasingly it seems that it's not really related to kind of viral invasion, but maybe a more coagulopathic immune-mediated type picture. But I think increasingly we're seeing that viruses are really important in thinking about causes of stroke.
Tom, if there is a minute for a question and comment, I think that Susie outlined a very important aspect of the epidemiology of viral diseases in Latin America. One of the emphases during the current pandemic of COVID-19 is clinicians need to be aware that it's not only COVID-19 producing neurological problems after February of 2020. There is still dengue, there is still Zika, there is still chikungunya, there is still Campylobacter, and clinicians need to be aware about establishing a very good laboratory diagnosis in cases of neuroimmunological or neuroinfectious disorders.
Yeah, I think you're right that we need to
just to add to that
the burden of the disease. Go, Taram.
Yeah, no, just to add, I think this has also not only from a clinical angle, but from a policy and surveillance angle, that it is important. I think the data that Susie showed in terms of different viruses that can be associated with neurological problems, and also co-infections. I think that shows that how we need to have better surveillance systems established and the diagnostic capacity strengthened across various parts of the world. So, this is about Latin America, but then there are different viruses that are circulating in Africa, Asia. So we need to build up those systems, in addition to the clinical patient care that we are talking about today. So I just wanted to emphasize this additional point, rather than, this is more a comment, Susie, rather than a question here.
Yeah,
Okay.
Very important. Thanks.
So we hand it now to Tarun to introduce our next speaker. Thank you very much, Susie and all.
Thanks.
Thank you. And so we move on to our next speaker, Carlos Pardo, who doesn't need much of an introduction. He's a professor of neurology and neuropathology at Johns Hopkins in United States. And he's the coordinator of the neuroviruses emerging in the America study based in Colombia. And he would be talking to us today about the impact of Zika plan from research to patient care. Carlos, over to you.
Great, thank you, Tarun, for the introduction, and thank you to Zika Plan and all the organizers of Zika Plan for the opportunity to get involved in this research project. It has been a great pleasure to be part of this consortium. The major issues that we deal in Colombia back in 2015, 2016 were basically related with an emerging outbreak that was very important in the context of the public health situation in Colombia. So what I'd like to bring today is basically what was the impact of the Zika outbreak in Latin America on clinical research and patient care. We are researchers, but our research actually needs to translate in a very important effect on public health measures, and particularly patient care. And while we are learning about the immunology of viral diseases, the virology and diagnostic approaches, actually the end point is patient care, and make sure that we have a very good investment in improving the quality of care of our patients. So I like to bring the example of Colombia and the network that was established in Colombia after the Zika outbreak. In Colombia, as Brazil and many Latin American countries, there has been a cycle of outbreaks of arboviral infections, particularly dengue. And we traditionally have recognized that in the context of the public health situation in many areas in the country. One thing that was very important is to recognize that actually preceding the Zika outbreak in 2015, there was a quite striking amount of cases of chikungunya that actually was overwhelming for the public health scenario in Colombia. But obviously Zika came, and Zika allowed us to have a much better view of the neurological problems. And I think that in the past we had ignored the neurological problems of dengue, chikungunya, but when Zika emerged, obviously the amount of Guillain-Barre cases indicated in this graphic in red versus the cases of Zika was really overwhelming. But one thing that probably we learned that after the period of Zika outbreak, there were still neurological problems and neuroinflammatory problems show up despite Zika was gone. And this is important because it's extremely necessary for many countries in tropical areas to be aware about the emergence and persistence of some of the viral diseases and infectious disorders. So in Colombia, in January of 2016, we established very quickly a network of academic centers, and basically with the leadership of a virology group led by Beatriz Parra and epidemiology by Lida Osorio, we were able to form an extensive network of neurologists, physicians, healthcare providers that basically tackle rapidly the concerns about the emerging problems with Zika, particularly neurological problems. And you are very familiar, that led to the description of the characteristic of Guillain-Barre in Colombia. But what I like to discuss with you today is mostly about the aftermath of the experience. And I like to emphasize that in the past a few years after the outbreak of Zika was basically over, we continue the effort in identification of neurological problems in the context of infectious disorders. So we continue an effort in identification of risk factors, but particularly one of the most important aspects is the improvement of the diagnostic capability, the diagnostic resources in Colombia and around the country, and particularly the establishment of this clinical network that facilitates a better understanding of the relationship of infectious disorders, particularly viral disorders and acute inflammatory disorders. So this is important because we need to improve, and one of the efforts that we have established for the network is to improve the therapeutic intervention, the capability to diagnose these patients correctly, and particularly to educate and disseminate information to healthcare providers that allow us to continue our effort to serve patients. So NEAS as a group is focused not only in the clinical analysis of cases that are acute neuroinflammatory disorders like Guillain-Barre, encephalitis, myelitis, but it's also an observatory that allows us the discovery of emergent viruses, and particularly the investigation of the association of viral disorders with acute neuroinflammatory illness. So we have established protocols. And this is important because Zika plan actually allow us to interact with many researchers around the world. And many of you in Europe, and many of you in Latin America, Brazil, have been very supportive of our efforts. And in the case of Guillain-Barre, the support of IGOS and the effort that has been invested in characterizing Guillain-Barre cases around the world actually serve very well in the purpose of the NEAS network. So up to date, we have been able to establish an observational study since 2016 that have accumulated more than 625 patients in a different spectrum of neuroinflammatory disorders, from Guillain-Barre to encephalitis and myelitis and other cases of neuroinflammatory disorders. But as you can see in this graphic that is derived from more than 620 patients recruited up to January of 2021, we have seen a majority of cases with Guillain-Barre, but also seen other patients with encephalitis and other disorders. And this observatory actually allow us to be ready to the COVID-19 challenge, and actually the laboratory resources that were established at the University of Valle and VREM with Dr. Parra and Lida Osorio actually allow many healthcare resources to be used for research and diagnosis of COVID-19 problems. So this is basically one of the bases of the network, is to be ready for rapidly response to emergent situations, including infections and viral disorders. One of the important aspects that are left from our experience with the Zika plan is that there has been a quite tremendous amount of investment in diagnostic resources and capacity. I mean, in the laboratory, not only the implementation of the classical techniques for virology and immunology diagnosis has been implemented, but also the introduction of new technologies like next generation sequencing, and actually the novel studies with the virus scan and toxome scan have allowed us actually to establish better links in terms of molecular biology, the immunology of the infection background of the patients, and have allowed us to identify even the links between previous infections like dengue with cases of Guillain-Barre in the context of Zika. Sonia mentioned the case of Peru. The network of NEAs actually facilitate the good interaction with our colleagues in Peru that were dealing with problems with Guillain-Barre. And actually, this was a very good example of transferring all the experience from a country that is similar to us, Peru, in which very rapidly we were able to respond to the challenge of an outbreak of Guillain-Barre and went very quickly to help our colleagues in Peru from diagnosis, immunology to even phylogenetics, and we were able to establish the characteristics of the Campylobacter jejuni, and even to determine by molecular approaches if this was a new strain that was emerging in Peru or this was just the circulating strain that was already in the world. And the conclusion was this was already a strain that had been observed in China, Africa, and Europe. And this is just a reemergence of a pathogen in a country like Peru. But one thing that probably is important to outline is what is the legacy of our projects supported by Zika Plan. One of the efforts has been characterize the patient population that was affected in 2016, 2017, and after by different immunological disorders, including Guillain-Barre. And we have paid a lot of attention to characterize the functional outcomes of those patients to determine not only the neurological outcomes, but also to determine the characteristic of social situation and access to healthcare. And that led to some of our young doctors and young physiotherapists and young healthcare providers actually to create resources that are going to be very helpful in our countries where there are limited access to physical therapy or rehabilitation. This is an example of one of the important projects that has been developed by some of our young rehabilitation doctors and healthcare providers that designed this app that is an app that can be used in Macs or any other platforms like iPhones and tablets that basically facilitate the process of rehabilitation when there is no physical therapist or occupational therapist next to the patient. And actually, this app is going to be implemented in Spanish and English and hopefully in Portuguese, and it's going to be a very good tool for patients for rehabilitation and recovery. So this is actually providing patients with better support. And I like to finish with the legacy of Zika Plan in Colombia and for NEAs. And it has been a very fantastic support because this allows us actually to implement a plan for 4 years to make sure that the NEAs continue to be an observatory for inflammatory and emergent viruses. And in that way, we are building capacity for laboratory research. We are bringing new technology like next generation sequencing and a phage-based technology for immunological diagnosis. But most importantly, we are investing in education and building human capacity to make sure that the new generation of healthcare providers, scientists, and physicians actually have the capability to use the molecular diagnostic tools, the computational biology tools, and all the new techniques that are going to provide better diagnosis from virology, immunology, and clinical point of view. And I'd like to finish just acknowledging all the players and particularly our collaborators in Europe to Bart, Sonia, Hugh, Tom, Susie, and all of the people in UMEA because it has been a great lesson for us and a very good resource for improvement of diagnosis and healthcare in patients with neurological disorders in Colombia. Thank you so much.
Thank you, Carlos, for such a wonderful presentation. And so please ask your questions by chat or unmuting yourself. And while people, they are thinking about their questions, Carlos, I can kickstart the discussion. So what are, from the Zika plan legacy, as you talked about, and the sustainability, what are your lessons learned and key messages for people who are now establishing neuro-COVID cohorts or any such longitudinal research studies? So what would you advise to do them much better, that there is more sustainability and scalability?
So one key element is the element of coordination of effort from epidemiology, laboratory research, and clinicians. One thing that we learned very well during the Zika outbreak was the language of communication. So I think that I need to acknowledge that traditionally in Latin America, the language of scientific communication is a barrier for development. And I think that in Colombia particularly, the ability that we have to establish a very good rapid communication between epidemiologists, public health provider, virology, and clinicians, researchers, actually was one of the key elements for the success of this effort. So I think the message for the future, and we are learning this during COVID-19 as well around the world, is communication and collaboration should be the major support for what we are doing in clinical research during outbreaks.
Thank you, Carlos. Just seeing if there are any other question for Carlos. Lida,
maybe in
yourself.
The meantime, while you look for another one. I think one key is actually to build capacity, to help each member of the cohort to improve their capacity to do research. Every member of the group, of the network, had to be better after being a member of the cohort. I think that in mind, it's very important. The strong members make a strong network. Yeah.
Thank you, Lida. Hugh, yes, you're
here, Taryn. Carlos, just in general terms, I mean, what you've presented is, of course, fantastic in an aspirational sense, and hopefully will become fully practical as well. But these are incredibly expensive networks to run, as people like Tom and Taryn and yourself know. So in terms of an overall sort of strategy for funding these kinds of enterprises, do you think we should be aiming for big things like Zika plan, or for lots of little things, or going to, you know, some of the bigger philanthropic charities than we have done historically?
Hugh, that is a very good question. We may need to reach to these large networks, and I think that this is the only way to go. In many ways, we have been successful because we had Zika plan, and we have been successful to submit applications to the National Institute of Health in the United States because we had that data that Zika plan allow us to produce. So I think that we were able to initiate our NEAS network in Colombia using philanthropic support. One family of one of our patients supported our efforts. But that actually allowed to invest more and more in the interaction that we had with you, and also the interaction that we developed with other researchers around the world for implementing things that were basically scarce or were not available in Colombia. So one of the philosophy of this network is building capacity for laboratory research, for diagnosis, and this is critical. And the only way to go with that is with the support of large entities like a Zika plan. I think that government agencies that support research should invest more on these networks, and the lessons from COVID-19 is critical. It's the only way to go.
Thank you, Carlos. Tom, just wondering how much time do we have, or should we hand it back to you for wrapping up?
I think that's a perfect time to hand back, and especially that final question and comment from Carlos. I think Annalise is going to join me, but Carlos, thanks very much to you and to everyone in that last session. for those thoughts and comments. I mean, I think the question about funding is a really important one. We have been funded because of the Zika emergency. Many of us have then built additional funding on the back of that. And now with the COVID emergency, we've been able to capitalize on that. But I think in some respects, one wants to retain the broader underlying networks. One doesn't want to keep reinventing networks and reinventing, the wheel, as it were. And so, one part of the legacy, I guess, is even if Zika plan has formally finished, we have whole groups of collaborators now who work together and working together on things like COVID-19, and will continue to do so. And it's important for all of us to, in our funding applications, just to make sure we allow a little bit for the kind of networking opportunities, the broader meetings, etc., that bring people together. Let me pause there for breath and to see if anyone else has any comments on that. I have a few final closing comments and then Annelise does, but did anyone want to comment on that sort of funding aspect and future perspectives aspect?
I mean, just Tom, just to add that I echo what you are saying. I think Zika plan and other cohorts or consortia that have been established, I think we need to have better and further mechanisms of collaboration and coordination and harmonization of the efforts that are, across the different continents. So, so bringing in the experiences from Latin America, Asia, Africa, Europe together. I think and there should be like funding for some, I would say, like a consortia of consortia, in a sense that we are able to learn from all these different experiences. And I think this could be an important message from Zika plan to different research and policymakers.
Yeah, I mean, I'm sure Annelise will have a comment on that, but one of the challenges is that people like to fund research. They don't like to fund networks as such, that aren't actually actively doing research. So, as long as there are emerging neurological problems, then presumably we will continue to get research funded. But it's more in peacetime. How does one keep people connected in peacetime? And Annelise, do you have comments on that before we do our final wrap up?
No, thank you for your comments on the legacy and how we've had many spin-off funding as well as spin-off research, and we have enlarged as a network of networks, and that is because Zika plans set the seed. Indeed, you correctly pointed out that the European Commission does not fund networks for the network's sake. So you have to have an original research question, hypothesis, and then work on it. But I think as a Zika plan, we have shown extraordinary spin-offs and additional funding, I think more than many other consortia before. And I think that's our legacy, and we need to communicate that back to the European Commission.
Thank you. Thanks, Annelise. Let me just say a few final words, particularly in respect to the seminar we've had this afternoon. I mean, I think it's been brilliant for us to get people together, even virtually, if we couldn't do it in person. And hopefully we've displayed the job approaches to tackling both peripheral nervous system disease and central nervous system disease, and to look at it both all the way from the epidemiological through to clinical and diagnostics down to disease mechanisms and basic biology. And we've had some beautiful of that this afternoon. And I think anyone who is watching and is new to the consortium will see how much interaction there's been, how much there's overlap. There are no silos within this Zika plan consortium. There's very much, it's all about integration and interaction. We've seen some really good impacts, both in terms of studying and impacting on Zika itself, and then also some of the slightly more remote impacts in terms of things like the fantastic Guillain-Barre Syndrome clinical approach that's been published and that's available as a web tool that applies to all aspects of Guillain-Barre Syndrome. I want to thank all the people involved. not just those presenters today, many other scientists involved who've not presented today, but who've made enormous contributions. We want to thank the funder, I'm sure, and also our team in UMEA who've given tremendous support throughout this whole programme. And, you know, working with EU funding is not the most straightforward thing, but the team at UMEA, particularly Raman, have kept everything on course beautifully and brilliantly. I'll just, before I hand over to Annelise, I will say I would like everyone who can to turn their cameras on at the end for our final goodbye. So if all the panelists will turn their cameras on, and we will all say a bit at the end. But Annelise, let me hand over to you at this point.
Well, thank you, Tom, and thank you to all the chairs and the excellent speakers. I really enjoyed today's webinar. So 1,000 thanks to the entire Zika Plan Neuro-Zika. So as Zika Plan overall scientific coordinator, it really has been a pleasure to working with all of you over the past almost 5 years, and new friendships have been built and new networks indeed have been established. If you are not part of Zika Plan and you are part of the audience and you would like to learn more about Zika Plan and our achievements, please do go and look up our website. Just Google Zika Plan and you'll get into it. You will find a detailed description of our projects, of our experts, but also our publications. There is also training material available, and so do have a look. I also want to add to Tom, again, words of acknowledgements and thanks. And central to Zika Plan is always our Zika Plan Executive Director, Dr. Raman Preet, with the hosting institution Umeå University in Sweden. Also heartfelt thanks, of course, now to the Global Health Network. Yes. Yes, those good old times where we had all these audiences. And then special thanks also to the Global Health Network, who gave us the platform for these webinars and really pulled this together very professionally. Many thanks to Bonnie Baker. Also, many thanks to the entire communication team at the Fondation Mérieux. So a lot of thanks to all of us. So the last words is about the next webinar. And that's our final webinar. So for our final, for our dissemination, we had planned a face-to-face meeting in Brazil, which is now not possible. And so we have 3 events in total. Today was the second, and our final one is on the 24th of March. And this really will focus on the legacy of Zika Plan. We will have panel discussions with the European Commission, with GloBIT-R, with other funders, Fiocruz within, and with the other Zika EU-funded Zika consortia. We will talk about the training networks, the capacity building, the laboratory networks, the clinical cohorts, and the clinical networks also related to neurology, as heard today. I think Lida Osorio's words we should end with those. Strong members make a strong consortium. So thank you for being strong members over the past 5 years, and let's see each other again on the 24th of March for the final legacy discussions. Thank you so much to everyone.
Thank you, Annelise. And of course, the one person we must thank, as well as Raman, of course, is you for your wonderful leadership of the whole consortium. So I've asked everyone to unclick their microphones, and we'll give a big to Annelise and all the whole team. And then, so if everyone could unmute your microphones, and then after 3, as is traditional for any meeting I host. So after 3, 1, 2, 3, goodbye.
Bye.
Adios.
Bye.